questions answered, and I do want to say that it was extremely hard to pick the questions because they were all fantastic. They're very detailed. We have people here in private practice who have excellent questions that demand answers.
How do we lower the cost of private insurance? People ask questions. I'll read you one question, and others are kind of connected to it. The most lucrative area for cost control in our healthcare system is found in the 20% plus insurance premiums, which go to non-healthcare administrative costs. What do you think is most saleable to the insurance companies? One, telling them that there's a new competitor on the block called the public option, or two, mandating that they change their business model to nonprofit. And a related question is thoughts on rate regulation of premiums, similar to utility rate regulation, in lieu of a public option. And the third related point I will read is from a private practitioner who said, the vast majority of my practice's reimbursement is set by contracted arrangements with insurance companies. So we already have contracted rates. So what is it that we're most likely to get? How can we lower insurance company costs?
Currently, the insurance people are taking somewhere between 20 and 35% as an administrative cost on that. And we understand that in the 1990s and back through there, the insurance companies were able to do that with a 6%.
Right.
And you simply have to just look like I did on my iPhone a minute ago and see what happened to the Cigna, the Aetna, and the WellPoint stocks from December when they went way down, and they've doubled and tripled. So we are being fleeced.
Yeah. So how do we treat it?
That position has some degree of truth to it, and it's a very popular position. But let me take the opposite position, because this is sort of public educational forum, and I think it's important that everyone hears sort of both sides of these arguments. Administrative costs are very high, as Jim has alluded to. A lot of this is not profits. Profits are, as much as anyone here objects to the profits going to pay high CEO salaries, it's only a very small portion of what we're paying in premiums. And even if we eliminate all these profits, it's not going to matter. Again, look at the fact that over half the people who are privately insured in the U.S. are insured through nonprofits, through places like Kaiser. A good deal of these overhead costs are spent in trying to separate out those costs which are needed versus those that are not. Now, if you're a provider, then you will object to the way that that's done, but the argument is that if they did not do that, your premiums would be even higher, because we see these high administrative costs even in areas that have very strong insurance competition, where each insurer has an incentive to undercut the other insurers out there given the current system. So I don't believe that within our current multi-payer system we're going to get a whole lot of cost by squeezing these administrative costs, unless we go to something radically different, which simply the public option is not going to do either, frankly, in terms of the administrative costs, unless we get a couple 100 million people on the public option. And we're seeing some of our private health insurance companies have 30 million people in them. I mean, they have economies of scale. They can do things without having to have huge cost per person in that same way. So again, as I mentioned in my talk, I'm much less optimistic that we have magic bullets for reducing these costs. We're seeing costs growing over time all over in European countries as well. And a lot of this is due to new technologies coming out there, which often we actually want to be paying for. And as we get richer and richer as a society, it actually makes sense that we spend more and more on healthcare in our society. What we'd like to do is squeeze out the inefficient parts of the system. And so to the extent we can squeeze out some of the administration costs create, I'm not optimistic with the non-single payer option we can do that. Or to the extent that we can make more rational some of the types of care that we're overutilizing, underutilizing, et cetera, that would be great. The other piece that we haven't really talked about here today is one of the reasons why we have increasing costs over time is increasing obesity. Okay? And obesity. And so it is the larger structure of our society issues which are affecting individual behaviors, affecting our sort of public health behaviors, the milieu in which we are living is leading to higher chronic disease burdens. Unfortunately, again, we don't have any magic bullets for attacking things like obesity. I think it's super important that we keep trying, but I'm not terribly optimistic that we're going to be able to ratchet down these costs tremendously.
Quick question, do you include advertising in the administrative?
Yes.
And what's the percentage of that?
It's in the marketing. I have to look it up. I'm not sure I have it separately, but all of the estimates of insurance company administrative costs include things like marketing, which is advertising. I just wanted to add, I completely agree with Will that the profits are a very small piece of this, but I would also argue that it's because we have a multi-payer system that allows companies to work and seek profits that the structure of the system is so complicated. It's sort of, in a way, it's the whole structure of our system is set up to serve the interests of people who want to make money within it. If we shift it to a single-payer system, we lose that opportunity to make profits. The profits themselves are small, but the impact on the system is magnified. And that's how we get from the 60 billion or so in profits up to the 400 billion in administrative costs overall.
I just want to add very quickly is the insurance company side is one side and is important for the reasons that have been stated. The other side is the provider side. And I think a lot of people seen Atul Gawande's piece in the New Yorker, but we've also got to get a handle on how providers are paid, what the incentives are in that system in order to move towards, and I mean, I think Will's point's fair. If we move towards more rational care, we could end up in a situation where we're not spending a lot less, we're just spending it a lot smarter, and so people are getting better health care, which I think we'd all agree on. I suspect there's a lot of savings there as well, but that's a whole question of sort of really addressing in terms of the delivery system side, and I think it's true, both the bills at hand take some steps in doing that around Medicare, which I think are important. But a single payer situation doesn't get us there automatically either. In any case, it gives you more levers. I know Will would argue it gives you more levers and also politics to push back. But in either case, that's something that's got to be addressed. Whichever financing system we go to, we also have to seriously look at reform and delivery system. And I think that has not received the attention that it needs.